Welcome. I'm Dr. Tanya Murphy. I'm a child and adolescent psychiatrist at the University of South Florida. I work in the Department of Pediatrics and have a joint appointment in psychiatry, and I direct the Rothman Center here. We treat children with autism spectrum disorder and related disorders like OCD and tic disorders as well. I do have some disclosures. It's all research funding and have no definitive conflict with this presentation, but they are noted as seen in the slide. I have worked with Florida Medicaid on guidelines. I did some advising on this guideline, but I did not actually participate in the work group for this guideline. Okay. So our objectives today is to discuss the recently updated guidelines for autism spectrum disorder and developmental disability that was done by the Florida Medicaid drug therapy for behavioral health. And we're going to go over the principles of practice and the most recent evidence-based practices for treating these disorders. You have a copy to download on the webinar here. For those not on this webinar, there are a couple of ways you can get it through the website or emailing Sabrina. So behavioral health in children is a very common problem that I think all pediatric physicians have to deal with. About 1 in 5 will have a diagnosable disorder, and probably about 2/3 of them do not get adequate treatment. Unfortunately, there's a shortage of child psychiatrists nationwide, and for those trying to get in to see a child psychiatrist, the wait can be quite long, sometimes much longer than the stated average 7.5 weeks. The demand has actually grown quite a bit in the last few years, but the places for child psychiatry residents haven't gone up significantly. So primary care physicians are being asked to provide the support for these needs in children. There are reports about 50% of all pediatric visits have some sort of behavioral or developmental aspect covered by that visit, and that 75% of those children being seen by are primarily being seen by their primary care doctors for their psychiatric presentation. It's sort of natural. The families have a long-term relationship with their pediatrician, and there's also less stigma in seeing their primary care provider than typically going to child psychiatrists. So you can see that a lot of the medications are actually more often prescribed by the primary care providers typically, and this is something that obviously a lot of primary care providers do not get a lot of education on during their residency programs. So the point of the Florida Medicaid guidelines is to improve the quality of health, improve the drug prescribing practices, monitor safety and quality of prescribing practices, and reduce clinical risk. We'll go over that more. Lower prescription drug costs while improving quality in the prescribing practices. Develop evidence-based and consensus-based guidelines, which we've done in various meetings over the years. Collaboratively review prescribing practices through analysis of pharmacy claim data, and provide educational and other tools for higher quality prescribing. So the principles of practice. You always want to consider when a child needs some additional help, does the medication benefit outweigh any risk that might come to that child? Obviously, we want one medication for one disorder if we can get away with it. So monotherapy is always recommended rather than polypharmacy. Avoid medications in the same class, so not using 2 SSRIs or 2 antipsychotics or 2 alpha-2 agonists, for example. Minimizing patient-family burden by using long-acting medications or sort of streamlining medications as much as possible. Obviously monitor outcome and adverse effects. Always in this population especially, start on a very low dose, lower than you might with another child with a similar presenting problem, and then go up very slowly. And then whenever possible, make one change at a time, so we, as a physician, you would know what's the benefit or the adverse effects due to that change. Autism disorders and intellectual disability are very complex presentations. And as we do more and more genetic investigations, we find a lot of these are maybe possibly due to genetic disorders as well. And they often come with a lot of medical complexity that we don't typically see in the average child presenting with ADHD or anxiety. So these children will require like a multidisciplinary treatment approach, and it's got to be individualized to their needs. All treatment should be, as much as possible, supported by scientific evidence. And these recommendations that we use are intended to help children in various settings, especially in primary care settings. So the guidelines that we're going to go over are going to go over some kind of the common presentations that we see in autism spectrum disorders and intellectual disability, such as hyperactivity, inattentiveness, and impulsivity, aggression, irritability, self-injury, explosive outbursts, and so forth, anxiety, restrictive and repetitive behaviors, sleep disturbance, and depression and mania. And the way the guidelines were sort of categorized was based on strength and safety. Level 0 is more of the comprehensive assessment, evaluating the child as thoroughly as possible. So level 0 is assessment. Level 1 is the first level of treatment where there's stronger consensus, stronger evidence. Level 2 is a little bit less obvious evidence or safety. And levels 3 and 4 is where there's mixed consensus, mixed scientific support, and maybe perhaps higher risk. So what do you do with the level 0? This is your detailed developmental and symptom history, examining all the behaviors that we just mentioned. Use of rating scales is recommended, and I know that in many people's busy practice that's really hard to do. There are some in the guidelines book, page 5, and I also put a link for a lot of the ones that you can download. Page 7, there's a typo. You want to do a full medical history and an exam in vision, hearing, and so forth. You want to check as much as possible for diet, nutritional deficiencies. These children often do have some vitamin deficiencies. Examine for a history of seizures, their sleep disturbances, other medical problems. Obviously, many of them need speech language treatment, developmental therapies, and OT. And obtain a really thorough medication history, looking at how the medications were used, what adverse effects they had, and what over-the-counter medications and nutritionals that they're using. Obviously, assess the family structure for safety and support for the child. You need to evaluate risk for harm to self or others. Nighttime wandering, that's been a really big problem with children with autism, is escaping at night and ending up in canals and lakes and so forth. Obviously, signs of abuse and neglect, as we all know that we should be examining. The behavioral inventories that I previously mentioned. And then based on all this, decide what other testing is needed, like a neurological assessment, genetic testing, and so forth. So most children with developmental disabilities and autism spectrum disorder will not need medications, so it's not the primary treatment. And we obviously we'll talk a little bit more, but you want to do all the supportive therapies and rehabilitative therapies as much as possible first. You want to aim your treatment at the most impairing symptom, and then also consider the treatment impact on co-occurring medical conditions like seizures and so forth. Obviously, early interventions can decrease some of these behaviors later on, so as much as possible that's within the realm of their insurance and so forth is to get things like ABA and so forth to help improve their symptomatology. Then obviously psychoeducation, so the parents understand what to expect as these children develop. So non-pharmacologic treatment. Behavioral therapies are very important, and there's actually fairly decent scientific support for a lot of those. Parent-child interactive therapy for those that are higher functioning and have more oppositional hyperactivity type behaviors, defiance. ABA for helping with self-injury behaviors, speech development, and so forth. Kind of behavioral therapy for the higher functioning children that have anxiety and sleep issues and so forth. Speech language therapy, physical therapy, and social skills therapy as needed. And then what kind of special education tracks they need to be in. So prior to beginning any medication, you want to make sure that any co-occurring medical cause has been ruled out. Always obtain blood pressure and heart rate at baseline and at follow-up visits. And baseline and follow-up EKGs are not usually warranted unless they have a history of sudden death in the family and they have a history of cardiac illness. And I also get pretty anxious if I have a child on many different medications, so when polypharmacy is in place and they're on certain medications that may cause QTC prolongation, for example, then I might check an EKG as well. So we'll cover the category of ADHD and inattentiveness and hyperactivity. Level 0, obviously the comprehensive assessment, as we mentioned, and rating scales, physical exam, and so forth. Then level 1 would want to start with stimulant monotherapy, and it's very acknowledged that a lot of these children have more adverse effects than the typical child with ADHD. So it's a reasonable first start. It's you know pretty quickly whether or not it's going to be a good medication choice for this child. It is a little bit trickier in finding what I call the sweet spot, finding the optimal dose that they're not going to have adverse effects but still have the appropriate therapeutic response. It has been helpful in as many as 50% of the children. The next slide reviews the RUB study, which is a large study, a multi-site study looking at methylphenidate in children with hyperactivity and PDD. It was a fairly young population, and their highest dose that they used in this was 0.625 milligrams per kilogram per dose. 49% of them were considered responders. There was a higher rate of irritability, and 18% dropped out due to side effects. So it is effective, but it's less effective than you might see in children with just regular ADHD without comorbid ASD. And the next level is guanfacine. And again, this is an alpha-2 agonist, therefore blood pressure medicine. So you need to obtain a blood pressure and heart rate at baseline and follow-up visits. EKG, again, not needed unless there's history suggesting that. Typically start with 0.5 milligrams of regular release or 1 milligram of the sustained release, and increase by a half to full milligram per week as tolerated and as needed for efficacy. Top dose is usually about 4 milligrams. And as much as possible, don't combine this with clonidine because you're getting, 2 alpha-2 agonists, 2 antihypertensives in the same, child, and adverse effects will increase. Atomoxetine is another one. It's at level 3 because it doesn't have quite as much support. Same thing, check blood pressure, pulse, consider LFT, especially if they're on polypharmacy or have other medical problems. You can start with 10 milligram dosing and go up gradually to about 1.4 milligrams per kilogram or a maximum 100 milligrams per day. The thing important about atomoxetine is that they need to be able to swallow the pill whole. So there was a recent, just about a month ago, I think, of the extended release. Intuitive is the brand name, looking at hyperactivity and ASD by Larry Scahill and colleagues. They used a dose range of 1 to 4 milligrams, with the most common dosing at the end of the study at 3 milligrams. The active group had a 43% decline in hyperactivity compared to 13% of the placebo group. There were some adverse effects, and most of them had drowsiness, large portion had fatigue, and decreased appetite, which I found actually surprising. And actually, a number of these children, I think about 37% or so, had irritability as a side effect. So it did not seem to improve irritability, but did improve hyperactivity and impulsivity. Atomoxetine study looking at ADHD symptoms and autism spectrum. 6 to 17-year-old children were studied. 1.2 milligrams per kilogram per day was what their target dose was, starting with 0.5 milligrams per kilogram the first week and then going up the second week. If this was the one that you're really counting on for benefit, only 19% of them showed very much improved ADHD symptoms at the end of the study, but did do better than the placebo. Adverse effects were nausea, decreased appetite, fatigue, and early morning awakening in this study. So level 4 is where you try to do combined therapies. So I think using a combination of a lower dose methylphenidate with an alpha-2 agonist is reasonable, or a stimulant with the atomoxetine is also reasonable, or then trying an amphetamine preparation for those that aren't improving. So anxiety and antidepressant treatment. Children with developmental disabilities and autism spectrum have a higher rate of anxiety, and this comes with a lot of sleep disturbance. Their communication difficulties often make it a little bit harder to assess, so sometimes you have to surmise that the anxiety is behind the reaction. These children have a lot, the neurological comorbidity that makes it also difficult to sort out sometimes. So for anxiety disorders, again, the comprehensive assessment at level 0. At level 1, initial treatment plan, looking at the co-occurring disorders, making sure that they have appropriate speech and so forth. And then if they have higher functioning, they can actually do cognitive behavioral therapy. And we actually have done a lot of this at our institution, and it is found to be effective in the higher functioning children to do cognitive behavioral therapy as a primary treatment for anxiety in this group. If that's not helping, or that's not a possibility, then considering sertraline or fluoxetine. There's not a lot of evidence that these will help, but these are considered the safest of the SSRIs probably for this group. Usually for these you want to start at what I call almost homeopathic doses. You want to start much slower than you might with other children. So typically about 5 to 6.5 milligrams or so of sertraline. You can use a liquid, and 2.5 milligrams of fluoxetine. Similarly, you can use a liquid if needed. So antidepressants that are generally used for a lot of different disorders, and sometimes you will see some of these in children with ASD and developmental disability, and especially some of the higher functioning ones will have these comorbid presentations. The major depression and so forth are also not well studied in this group, but this is something to consider if you're seeing a child with this presentation. Thanks. What we know about the medication responsiveness, just to kind of give you a background, is that the non-OCD anxiety disorders actually have the best response to SSRIs, and the number needed to treat is only 3 for the non-OCD anxiety, but 6 for OCD and 10 for major depressive disorder. This is in non-ASD children, but showing that if you have just a more of a pure anxiety disorder, that the benefit is actually probably better than you might see with other disorders like depression and OCD. The general SSRIs that are out there, there's a range of dosing, and I have those listed here. There is FDA approval for most of these medications for something either OCD or major depressive disorder. For some of the anxiety symptoms, and specifically for ASD, Fluoxetine has been used, as I mentioned. Buspirone has been used in some, not a lot of scientific support for this, but it's a fairly benign medication to try. And mirtazapine has been used for some of the anxiety disorders, also for sleep. And actually, interestingly, it has been studied in some case series and open label studies for excessive masturbation in the autism spectrum disorder, and have been found to be helpful. So it's a sort of a outlier indication there. The side effects of SSRIs, generally children don't present with telling anybody that they have sexual side effects. You'd have to ask. GI symptoms are sometimes seen, tremor, weight loss, headache, fatigue, but the most common side effect is behavioral activation. The next slide. And this is what we typically have trouble with especially when we're treating some of the autism spectrum disorder children, is that you might get into an iatrogenic situation of if you're using SSRI, you might find that the child is getting hyperactive, and if you don't realize that the medication could be doing that, then you might find that you're needing to put another medication on board to treat the hyperactivity. So always look for iatrogenic causes when you're using SSRIs. So akathisia, hyperactivity, increased irritability, increased moodiness, and even frank mania can happen on SSRIs. And I would say that the ASD and developmental disability groups are more likely to have these side effects than the typical child. And the typical child actually occurs quite often, probably 25% of the time. So the treatment of these disorders rehash more paradoxical reactions when you try to treat their anxiety and repetitive behaviors. Some of them do respond to traditional therapies like cognitive behavioral therapy. They often need smaller starting doses, and in co-occurring conditions, having multiple disorders presenting is very common. And always make sure that medications or infections are not part of their anxiety presentation. How long do you use an SSRI? Typically, for a lot of the anxiety disorders and restrictive repetitive behavior and OCD, you would want to go 10 to 12 months for your full benefit. If at that point you're not seeing some trend towards benefit, then it may not ever get to be to full efficacy. And so I would at least give it a couple months before you decide to try something else. Obviously, if there's adverse effects, then I would either decrease a dose or withdraw the medication. Typically for anxiety disorders, you want to treat for about a year and then gradually taper them off slowly over a period of time to keep from having flare-ups and relapses. Aggression, irritability, and mood symptoms is something that we see a lot in children with ASD. Again, level 0 comprehensive assessment, and making sure that contributors to irritability like headaches, constipation, sleep deprivation, trauma, being bullied, sensory overstimulation, those are not contributing to their irritability and aggressive outbursts. The rest of it we've pretty much covered, but developmental exam, EEG, MRI, obviously if there's concern that this is because of a neurological presentation. Level 1, obviously, again, psychoeducation, behavior therapy when you can get it, speech-language treatment, because a lot of times these children are exploding or getting frustrated because they cannot communicate as well as they would like. Family treatment, the PCIT for those 7 and under with a lot of the outburst, social skills treatment to help with social management and obviously to help the integration into social settings, treatment of the co-occurring conditions, and the overall multi-systemic treatments. So for level 2 antipsychotic therapy, currently we have approval by the FDA for aripiprazole and risperidone to treat these specific symptoms. It's one of those few instances where it's not for the disorder itself. So if you have a child that's presenting autism spectrum disorder, it doesn't mean the FDA has approved medication for autism spectrum disorder but just specifically for the irritability and aggressive outbursts seen in some children with autism spectrum disorder. You want to start with really low doses. I'd say 0.25 for the typical child, even lower for if it's being used for preschooler. Go up slowly, and typically you're not going to go above 3 milligrams or so per day, which is really basically the adult dose. Aripiprazole, you could start with 2 milligrams or half a 5 milligram tablet, and go up every 1 to 2 weeks as needed, topping out at about 15 milligrams. Beyond that, you're getting into high dose, and there's not really a lot of evidence that you're going to get much more, efficacy beyond the 15 milligram dose. If no response to either of those, obviously re-examining what's going on with the child, and you can consider alternative antipsychotics that have been used for other pediatric indications. And always monitor for adverse effects, and we'll go over that more later. Depression or bipolar, there's unfortunately not a lot of information to help support treatment for these children. So generally we just have practitioners refer back to the general psychiatric guidelines for children that Florida Medicaid has put out. That's fine. Okay, sleep disorders, very, very common problem in this population. And so first of all, comprehensive assessment, and specifically regarding sleep, you want to make sure that they don't have obstructive sleep apnea, which can be a fairly common condition, especially in those that are overweight, but even normal weight children can have this presentation. Restless leg syndrome, which can often be confused with ADHD. Circadian rhythm disorders and narcolepsy, less common, but can be present. GERD is often fairly common in this population, and that's something to consider if that's causing them to awaken in the middle of the night. Anxiety disorders also interfere with sleep and can be part of the problem. Also look at medication causes. If the medication is keeping them awake, that's fairly common with some of the medications we do use, like the stimulants and SSRIs. Looking at their sleep pattern, making sure that they're not taking excessively long naps, and then not sleeping because they've had already enough rest for the day. Caregiver role, that's sometimes a lot of children will get anxious and want to sleep with a parent, and sometimes that becomes more of a habit after a while. So just looking at the interaction between family members. And then just looking at, do they have more difficulty falling asleep, or are they having trouble staying asleep or waking up in the middle of the night, or are they having early morning awakening? So those things need to be sorted out. Obviously there are sleep training procedures that can be put into place. These are more behavioral. CBT for older individuals is a reasonable approach. There's a web training program. Healthy sleep practices. A lot of the children that I have, especially as they get into their middle childhood and teenage years, they're always on the TV, computer, iPhone, iPad, and the light is obviously probably not allowing their circadian rhythms to behave naturally. And so I have them try to cut these off by evening time, or to have dimmer lights in the home so that their circadian rhythms can be more functional. Limit caffeine obviously is pretty obvious, but you would not think to ask sometimes a young child how much caffeine they're getting, because we don't think of a lot of children drinking coffee and sodas a lot, but I've been surprised sometimes when I heard parents tell me that their young child actually does drink coffee. So the first medication that we would recommend is level 2 is using a good quality melatonin. There's a lot of support for this in the literature. The downside that we have is that the melatonin is not regulated by the FDA, and so it can be large variation in the quality of the medication and in the dose of the medication. So you may not even have, a 5 milligram tablet may actually have like 0.5 milligrams in it, because there's nothing that's controlling that in our current environment. So that's something to be mindful of, is try to have the families buy a good quality one if you're going to use melatonin. And going up to 10 milligrams per night has been safe. I typically try to stay around 1 milligram if at all possible. The level 3 is clonidine, and whenever possible, use many of these medications short term. This has been fairly effective. It's very good for sleep onset. It's not particularly as good for early morning awakening, and sometimes they can get a sort of a rebound awakening after the medication wears off because it's fairly short acting. Typically the range is a half a tablet of 0.05 milligrams per night, and rarely going up to three tablets a night. Obviously monitor blood pressure and pulse, and if they're on a larger dose, avoid abrupt discontinuation because they can get like a rebound hypertension. There's limited evidence. These are not on the guidelines for trazodone, low dose, and then mirtazapine, low dose as needed, and then hydroxyzine for sleep, 12.5 to 25 milligrams would be reasonable. Repetitive behaviors and SIB. Typically repetitive behaviors only become a problem if they're like, if the child is engaging in them so much that it's interfering with learning, or if they become self-injurious. A lot of times children have these behaviors because they serve a purpose in helping them self-modulate. So you have to kind of look at the context of the repetitive behaviors and how much impairment they're causing. Having repetitive behaviors alone is maybe not enough to consider medication or other treatments, but if it's becoming impairing or injurious, then obviously medication may be warranted. There's a lot of different repetitive behaviors in the context of autism spectrum disorder. We're typically talking about stereotypies, but they can also have compulsions, and they can also have self-injurious behaviors. And children with autism spectrum disorders are more frequently likely to have tic behaviors as well. Typically these are not the target of treatment, and if, like I said, they need treatment, cognitive behavioral therapy can be tried. There's really not very much literature about treating stereotypic behaviors and restricted repetitive behaviors in this population. ABA might be worth trying, but there isn't a lot of support, so it's mostly using your best guess, unfortunately. So level 0 comprehensive assessment, examining the context, also making sure that they're not caused by a neurological condition, that they're not seizures and myoclonus or spasms and so forth. And then level 1 is the treatment plan. You treat co-occurring conditions, make sure that sleep issues are treated, that you educate the parents about the repetitive behaviors, because a lot of times they're more disturbing to the parent than they are to the child. So if they're not causing the problems I had mentioned before, then pretty much would not actually act on treating them. And CBT adapted for autism spectrum is also a reasonable approach. Antipsychotics. So there's evidence now, largely it's been funded by a lot of the big pharmaceutical companies, to look at using antipsychotics in children with bipolar and schizophrenia, and a lot of them do have indications for these disorders. There is no evidence really supporting using really high doses in children of these antipsychotics and using more than one antipsychotic. Also, I would point out there is absolutely no evidence of using long-acting injectables in pediatric populations, and definitely not in autism spectrum disorders and developmental disabilities. That said, the antipsychotic prescribing is tripled in the last several years with all the new atypical antipsychotics that have been developed. And it seemed to be disproportionately higher in those with a lower family income and in minority children. And actually one study supports that 2.4% of all children on Medicaid are actually on antipsychotic. So this is something to be very mindful of. We're getting more and more studies here recently, but there isn't a lot of scientific evidence of long-term safety, so that's something to be mindful of. But then there is genuine concern about weight and metabolic side effects with these medications, and we'll go over those a little bit more. And there's also a greater tendency for them to have cardiovascular adverse effects in children than in adults, so something also to be careful about. The chart here shows the FDA-approved atypical antipsychotics for children. Risperidone, aripiprazole, quetiapine, olanzapine, and paliperidone have been approved. For schizophrenia, a little bit similar approvals for bipolar, but only risperidone and aripiprazole, like I mentioned earlier, for autism spectrum disorder. If antipsychotic is going to be needed, obviously you want to get a height and weight at baseline and at every visit, blood pressure and pulse as well. Baseline aims or discus, and I see this a lot in chart reviews, is that medication is started but the doctor has not thought to do an aims or discus to measure baseline extraneous movements. You want to do these at least 3 months while you're titrating the dose, and then every 6 months once they're on stable dose. Obviously try psychosocial treatments first. And obviously kind of know what you're treating, what's your target symptom and what's your goal for that symptom. Starting low and going up gradually is in the child's best benefit, and then giving them information about that these medications may cause weight gain and metabolic issues, and advocating as much as possible, although I understand this is a difficult population to do this sometimes in, but about eating properly and exercise and so forth. We don't recommend olanzapine ever as a primary treatment, and none of the combination medications, and never would use long-acting injectables as a primary treatment approach. So why would we monitor these children more carefully? There are increased rates of metabolic syndrome and cardiovascular conditions, increased rates of type 2 diabetes, and now we're seeing a lot in children, and obviously childhood obesity is almost an epidemic proportions lately. Why do we measure aims in the discus? We're looking for extrapyramidal side effects, dystonia, which would be an acute spasm typically of the tongue or neck, akathisia or restlessness, Parkinson is the rigidity, they have a cogwheeling if you check their elbow movement, and tardive dyskinesia, which can be a permanent condition of irregular stereotypic movements of the tongue, the mouth, the hands and feet. And so this is something that we would catch early if you're doing the aims at each recommended interval. Hyperprolactinemia, we're hearing sometimes on the news about lawyers suing for gynecomastia and people treated with some of these medications. This is sometimes a possibility, and so the issue of measuring prolactin levels has not routinely been endorsed by a lot of the guidelines, but certainly if there are adverse effects that might indicate that a prolactin level is involved, like period irregularities, gynecomastia, galactorrhea, sexual dysfunction, and so forth, then measuring a prolactin level would be helpful. All the antipsychotics can increase prolactin except for aripiprazole, and in that case a lot of times it actually seems to decrease the level. Ones that are particularly prone to causing prolactin increases are risperidone and paliperidone. Weight gain and obesity obviously are problems in children using these medications. So the FDA issued a warning in 2003, and the American Diabetes Association, American Psychiatric Association recommend glucose and lipid testing for all patients starting these medications. So with that, there's still been lower than ideal monitoring by users of these medications, and so this is something that I think everybody needs to work on. Just released this past week looking at type 2 diabetes risk in children treated with antipsychotics. It was significantly greater in males versus females, those treated with olanzapine and those that were using it for a longer duration. It was higher overall, didn't seem to be quite as high in the children with autism spectrum disorder, but still enough to be concerning. So routinely monitor height, weight, BMI at every visit, and you should convert the BMI to age percentile for that child. And you can get those off of the CDC website, and a Medicaid website may have those as well. Pulse and blood pressure at every visit. The Ames disc is baseline 3 months and then 6 months thereafter. Labs that we recommend, typically safety labs like a CBC and a CMP is regularly recommended at baseline, and fasting glucose, lipids, hemoglobin A1C, and then 3 months while you're dosing, and then 6 months after, every 6 months after stable dose. If they're having a lot of evidence of metabolic issue going on, especially like high weight gain and already having obesity, you might want to increase the frequency of this monitoring. So how do you handle these adverse effects? They're very difficult, but you want to consider as much as possible lower the dose. Teach the family healthy living. They sometimes the children will gain weight even if they're not consuming more food and so forth. So this is something that becomes a bit of a challenge. You always want to monitor for the neuromotor adverse effects, like we said, using the scales. Those are free and downloadable from the websites. Parkinsonism, you would see this more with a high D2 blocking agent, sometimes like risperidone and so forth. And this is where the child is psychomotor slowing and they have low facial expressions and so forth. Dyskinesia and akathisia, lower the dose, you can switch to a different agent, and sometimes you can add on, sometimes like Benadryl or benzodiazepine if this becomes a problem and you can't lower the dose. Some references and resources. There are the guidelines on the Medicaid website. You should have a link to that in the webinar. The American Academy of Child and Adolescent Psychiatry has an autism spectrum guidelines. It's very useful. Autism Speaks has nice free downloadable toolkits for families that go over treatments and so forth. CDC has a nice link. And then in Florida, there are regional card centers that are often very helpful for families and practitioners if you reach out and ask for help or have see what services they offer locally.
I believe that was the last slide.
All right. Well, thank you.
All right. And at this moment, we're going to go ahead and open up the chat for any questions. We'll leave it open for a minute. If we get some questions, Dr. Murphy will be willing to answer them. Mark Morris asked, tell us more about current thinking on ABA.
ABA has currently some of the strongest support for early intervention. It needs to be done by somebody that is trained, and ideally it is done as intensively as possible. Some of the better outcomes has been when the children get 20 or more hours per week. It's less supported typically for older children, but it can be beneficial for specific behaviors, and should be covered by insurance companies in the state of Florida.
Just had a few other ones come in. One of the questions asked is, have you seen an increase in irritability or behavioral outbursts in female adolescents or young female adults around menstruation or ovulation? If so, how is that managed?
Yes, this is sometimes a problem. We've even had some that, if they have seizure disorders, and more likely have seizures at that time as well. One of the treatments would be to kind of consider having them touch base with their gynecologist, and some of them can go on long-term oral contraceptives or hormonal therapies, typically at 3-month intervals, to decrease this irregularity. There is some support for SSRIs being dosed at 2 weeks prior to the menstrual period that might decrease mood swings, aggression, and outburst. This has not been studied, as far as I know, in autism spectrum disorders, but it is a typical standard therapy for those that have late luteal phase disorder. So I would say one of those two approaches would be the most ideal ways to start with that.
Excellent. Another question that came in says, do you know if a lot of pediatricians are managing ASD kids with psychosis on their own?
I'm not aware of a lot of them doing it on their own. I think sometimes they get stuck in a place where the child is not able to get into a psychiatrist to manage their care, and sometimes they are treating them on their own. And some of those call me from time to time, and so I'm aware of it that way. I wouldn't say it's a high portion, but I am aware of that happening, and that is a pretty difficult place for the pediatrician to be.
And the last question that we have, it says, what can we do to get children with Medicaid into psychiatry?
Well, the problem has been, at least in Florida, is like for a while I was aware of many of the community mental health centers not accepting children with autism spectrum disorder, as that was felt to fall into the developmental disabilities agencies. But clearly they have comorbid psychiatric problems and are better managed by psychiatry. And I think more and more of the community mental health centers do manage children with autism spectrum disorders and developmental disabilities. I think that has gotten better in the last 6 years, but I know that's been a problem in the past. Obviously, funding is a problem, as Medicaid reimbursement for community mental health psychiatrists is pretty low, so improving reimbursement would also be helpful. Increasing the number of child psychiatrists in the state would also help as well.
Excellent. We just had 2 more questions pop up. One says, what might be the symptoms of psychosis in a lower cognitive functioning child?
It would be somewhat similar to what you might see in a higher functioning child. Obviously, they're not going to verbalize quite as much, about seeing things or hearing things, but responding to stimuli that don't appear to be there. Some of these children talk to themselves anyway. That doesn't mean that they're hallucinating, so it gets a bit tricky. Responding to in a strong way to something that doesn't appear to be in the environment. So like they may be startling or are becoming acutely afraid without anything being obvious. Delusional thinking, I think it's less common, but hallucinations probably would be more common. It would be just, responding to things that aren't there and reacting to things that aren't there.
This question says, if the psychiatrist is treating for psychosis, do we assume that they will monitor with labs screening for choreothosis?
As a pediatrician, it's not always the case. I have seen many psychiatrists that feel that the metabolic monitoring should be done by their primary care, and there are many that will actually do it themselves. So I think it varies from what I've seen in the state of Florida. But certainly all psychiatrists that are treating these children with antipsychotics should be doing the AIMS on them on a regular basis.
All right, a follow-up question to that from the same person says, do pediatricians need to worry about monitoring with labs, AIMS, discus, if being treated by a psychiatrist?
If these are being monitored by the psychiatrist and there's not any gaps in the medical evaluation and care of the child, then I would say that the psychiatrist should be fine with doing that monitoring. The only time that I would suggest that is if there are gaps and it's clear that there's monitoring that should be going on that's not occurring, then I think the pediatrician is certainly free to step in and do that. But if they're not prescribing the medications, they're usually not the ones that do this monitoring unless the psychiatrist has indicated they want the primary care to do the labs.
Do ASD children in foster care need a different approach from others?
I That's a very complex situation, and children in foster care actually, if they were going to be treated with any kind of psychiatric medications, will need a special consent approach, and so it's best to know about that consent approach, because some of the children are getting started on medications without having their prior steps completed. But other than that, the higher risk for loss, depression, PTSD, just like you would with any child in foster care, should be considered.
We had another one come in. It says, what do you do when you have an adolescent that has been diagnosed with ASD, mood disorder, ODD, and personality disorder? The patient has been on many medications, is currently seeing ABA. Traditional counseling hasn't been helpful.
Unfortunately, there's a lot of those out there. If ABA isn't helping and the medications aren't helping, it sometimes gets really tricky because some of these children, to take them off medications is a kind of can be a high risk situation with outbursts and self-injurious behaviors and so forth. It would be ideal if we had a place to hospitalize them to do medication transitions like tapering, and then seeing how they do off medications, because in some cases the child may be actually behaving more because of the medications rather than because the medications are there. We have a lot of those children in the state of Florida, and there's not a lot of good care for them. And the other thing that you run into is when they get to be at such a large size, and how do you manage them? And that's another area that's very complex and very tricky to manage.
And the last one, would residential be the next option?
It might be, and there are a few facilities in the state of Florida that are sort of designed to take children with autism spectrum disorders. I've heard of a few of those, and if somebody wants to email me, I can give you those. But yes, that might be the next step.